This debate is about ambulatory nasal surgery. We'll start with a tour of the panel. Gentlemen and lady, if I just may ask that you introduce yourself briefly.
Hello, I'm Sean Carrie. I'm a consultant rhinologist in Newcastle upon Tyne, and I'm going to be giving a short presentation about ambulatory nasal surgery.
I'm Claire Hopkins. I'm a consultant rhinologist from London in the UK.
My name is Jannis Constantinidis. I'm a rhinologist and I work in the university department in Thessaloniki, Greece.
I'm Joaquim Mullol. I'm an ENT specialist. I'm working at Hospital Clinic, that is a university hospital in Barcelona.
I'm Emmanuel Prokopakis. I'm an ENT specialist at the University of Crete, Greece.
My name's Andrew Nill. I'm a patient. I have chronic rhinitis syndrome with nasal polyps, also with asthma, and I'm from London.
My name is Andreas Leunig. I'm trained in ENT, now specialized for rhinology, and I have built up a rhinology center in Munich.
My name is Philippe Rombaud. I'm an ENT surgeon, focus on rhinology, and I'm working here in Brussels at the University of Louvain.
And hello, my name is Brecht Cardoen. I'm an associate professor at Vlerik Business School, but also at the University of Leuven in the field of healthcare operations management, so more on the optimization side of processes.
Dr. Carrie, may I ask you to introduce the subject, please?
Thank you. So this is not entirely a new technique because ambulatory nasal surgery is practiced sporadically around the globe, really. But I think, given where we are in time, it's probably a useful topic to revisit. My sort of interest in this, I remember, really goes back a long number of years, 15, 20 years ago, performing some endonasal procedures in the operating theatre under local anaesthetic, things like dacrocystorhinostomy for teared duct issues, for excessive tearing, some local anaesthetic nasal polypectomies in patients who either didn't want to have a general anaesthetic or were not suitable for a general anaesthetic. But they really were few and far between, and they were generally, the decision was surgeon-based rather than patient-based. The thing that really sort of sparked my interest was about 2 years ago when I was operating in my operating suite. I was doing a list in my operating theatre, and one of my colleagues was doing a list next door. And on that morning list were 3 patients listed for endoscopic nasal polypectomy. And the list started at 8:30 in the morning, and it ran on to around about 1 o'clock in the afternoon. And for that duration, 3 patients had surgery. And I thought there's possibly a better way of utilising our scarce resources than we're doing so at the moment. And the model that sort of piqued my interest was that of going to the dentist. If you can attend the dentist fully dressed, sit in the dentist chair, have a local anaesthetic, and have a wisdom tooth extracted, or other root canal work, significant dental work, we're not really missing a potential option for some of our patients. So we've, over the past year to 18 months, developed a model in Newcastle upon Tyne of provision of ambulatory nasal surgery. And that nasal surgery is clinic-based, it's not operating theatre-based, it's local anaesthetic-based, it's not general anaesthetic, and there is no provision for sedation. So it's local anaesthetic, outpatient nasal surgery. And what are the drivers behind this? The drivers, one of the main drivers actually is patient choice. Patients expressing a preference to have a procedure done under local anaesthetic. Patients are aware that more and more now is possible in a local anaesthetic setting. They're aware of day case units. They're aware there's a movement towards less invasive procedures. And certainly in the UK, patient choice is a big headline in the NHS patient experience. I think as clinicians we're becoming increasingly experienced using our instrumentation in a general anaesthetic setting that wouldn't really trouble us in a local anaesthetic setting at all. And new technologies, the smaller telescopes, the 2.7 millimeter telescope, the pediatric microdebriders, the pediatric instruments really lend themselves to performing procedures under local anaesthetic. But as well as the patient choice and the surgeon preference, certainly in the UK we've got huge problems with long waiting lists, and that goes back to that initial procedure I was telling you about, where patients are waiting 6 to 8 months for a standard endoscopic nasal procedure, whereby we can get some of those patients in to the clinic much more quickly. And this goes back to the issue of limited resources. We have an increasing demand for services, but we don't have the resource to provide that unmet demand. And I'm fortunate, I work in an organisation which has a culture of innovation, and I think as surgeons, we're by our nature innovative. We're always looking to do things differently and try and improve on what we do. So we've got a team of 3 of us at the top there, and this is our local anaesthetic setting. You can see with a stack, microdebrider, and a patient having surgery under local anaesthetic. So we use a simple recipe, both in terms of how the patient is processed through the department and also in terms of the anaesthetic that's provided to the patient. So the patient arrives in the ENT clinic and has previously had a pre-operative assessment in the same way that a patient would have a general anaesthetic pre-operative assessment, looking at general health and allergies. The patient has topical anaesthetic placed into the nasal passages using these neuropathies that you can see there. And we like to think that's all performed in a relatively relaxed environment for the patient before they're taken into the dedicated room where they have their procedure undertaken. And after about an hour or so of recovery, we discharge our patients home. So we may have patients coming in on the morning of surgery, having their procedure, being discharged, and going back to work the same afternoon. So we have looked at some of our data. We're busy at the moment, after a year to 18 months of data, doing a microcosting analysis comparing a cohort of local anaesthetic with general anaesthetic patients. But in terms of our patient satisfaction, you can see that satisfaction with the procedure at 2 weeks and at discharge is equal in both groups. We have a significant reduction in length of stay. An ambulatory setting is 3 hours down from an average of 6.5 hours for inpatients. And then along the bottom there, you can see that our side effect profile for local anaesthetics in green is very small and very different, of course, to the side effect profile that one might expect from a general anaesthetic procedure and the initiation of general anaesthesia on those orange bars. So, and my final slide. So, overall, we feel that this has been a win for both us as clinicians, but primarily for our patients. I haven't purposefully gone into the groups of which patients we should offer this to, where perhaps we should do it, what sort of instrumentation you'll require, and the risks and potential rewards to us as a healthcare provider initiating procedures under local anaesthetic, because I think that's going to be discussed as part of the debate. So, thank you.
Thank you.